So we have with us taking the lead role is now Dr. Ritin Goyal, who is a cornea and anterior segment surgeon from Goyal Eye Institute, Delhi. And he is going to set the ball rolling with a very important talk of the present day. How would I do my topo-guided planning in regular corneas? On to you, Dr. Ritin. Could you share your screen?
Thank you, Dr. Chitra, for the kind introduction. And thank you, ma'am, for giving me this opportunity. I hope my slides are visible.
Yeah.
And I'm audible.
Yes.
Okay, so thank you. And I'm going to start, I'm going to talk about this topic about topography guided ablation in a normal cornea. In the current age, we are doing a lot of refractive surgery. Everyone's doing a lot of refractive surgery in the OPD. I'm sure all your patients are asking about Contura Vision. Contura Vision is essentially Alcon's name for topography guided ablation in a normal cornea. And I'm in this presentation going to talk about how I do the planning for these procedures.
You have yours next, yeah.
So I have no financial disclosures to make at this point. I'm a Alcon EX500 user, and my talk will be especially relevant for other Alcon EX500 users, but the principles are the same if we try to look at other platforms that have the same flying spot technology and the topography link. So the 4 P's that my presentation is going to cover is the principle of the procedure. What is the potential of this technology? How do we do the planning? And what is the root cause? What is the main problem in this planning? And what is my solution to that problem? So if we go on to the procedure, to the principle of the procedure, it's very simple, just like any refractive surgery. We have a patient with existing case or anterior corneal curvature. We're going to do an ablation in their eye, and we are targeting E, which is emetropia. So in this equation, rather than doing just a refractive correction, we are also adding topography guided ablation with it. So A is refractive ablation and TG is the topo guided ablation, and we're going to do it together. Now, just to understand why is this topography guided ablation important, or whether it makes any sense, or is it a marketing gimmick, I'm going to take an irregular cornea. The reason for taking an irregular cornea is, on a lighter note, if you would to look at an advertisement of a detergent, you can only find out if it works if you have a dirty clot to start with. So if you look at an irregular case here, you can see that the patient has significant inferior steepening on anterior sagittal curvature maps. This sort of inferior steepening you would see in cases of keratoconus. On this, we are doing a topo-guided ablation, and these are the kind of results that we can get. So if you have a cornea that is quite irregular, you could subtract some amount of corneal tissue from it, and you could make a regular shaped corneal anterior surface. With this idea, if we could use this in refractive surgery, where we are anyway shaving off some corneal tissue for refractive correction, could we make a normal cornea even better? So that's the idea. So how do we do the planning? We take our patients' preoperative data like the pentacam, and we know their anterior corneal curvature. The next thing we want to do is refract these patients. After a good refraction, we have the ablation profile. If you look at this ablation profile, it's nothing new. It's a simple myopic ablation. We do a good topography of this patient, multiple repeated topographies with a topolyzer, and we get the machine to suggest the minimum topographic ablation that it needs to do to regularize this cornea. This is an automatic feature of the machine, and this is based on the Zernicke analysis of the cornea. But without throwing too many technical terms, to make it really simple, The anterior surface of the cornea has some undulations. This ablation profile is looking to smoothen out those irregularities. If you look at the ablation depth, the topography guided part where we are only regularizing is hardly ablating 8 to 9 microns, whereas the total number where we're doing the refractive correction, that's where the bulk of the ablation is going. So the treatment is actually done as a single combined procedure, and this is what the ablation profile looks like. So what's the problem? The problem is that we've been doing refractive surgery, laser refractive surgery, for last 20-25 years, maybe or nearing now 30 years. And ablative refractive surgery has had excellent results. It is probably one of the most best accepted surgeries in the world. The results are marvelous. What we've been doing is we do a good subjective refraction of our patients and we get excellent results. Now the problem is, if we are going to do that, and to that we're going to add some topographic ablation, I'm sure you and I were both thinking this topographic ablation is going to have a refractive bearing as well. So when we were targeting emetropia with our original refraction, if we are going to add topographic ablation to it, for sure we're going to miss the mark. So what's my solution to this problem? I look at this topographic ablation first, even before doing refraction. I look at what is the difference between the center of this ablation and in the periphery. So if you can make out the center is about 4.5 microns, that's the ablation, and the ablation in the periphery is going to be around 8.5 microns. The difference is just about 4 microns or 3.9 microns in this case. If I was to extrapolate this and change this ablation pattern to something more regular, it would look kind of like a hyperopic ablation. With a 0.25 diopter of hyperopic ablation, we would be treating around 3.9 microns in the periphery. If I try to extrapolate this a little further, it would look like a 0.25 cylindrical ablation, which is also a hyperopic cylinder ablation. Here too, the max ablation would be 3.9. Considering that if I would add the two, it would be very high. Let's take half of both, and let's take it that the net effect of this this topographic ablation would have a refractive effect of plus 1.12 diopter sphere and plus 0.12 diopter cylinder. Now the refractive ablation being as it is, we know that the topographic ablation is going to do some hyperopic treatment. My suggestion is just convert this entire hyperopic treatment into a sphere and treat your myopia just that little bit more. So 0.18 diopters extra in this case would be what I would apply for my final ablation treatment. So just to summarize, we'll take the two of these, combine it into a single one, and this is the treatment that I would do. And so far, my results have been pretty good, and I've been quite happy with this idea. So my 2 cents about this procedure and the way that I'm doing it is do your topography before doing a subjective refraction. Make sure that you are either that you are under or overcorrecting the cell by less than 0.25 only. So say if your patient is accepting 1 diopter of cell and you're seeing that your topographic ablation is also going to treat about 0.25 of cylinder in the same axis, you can sort of undercorrect the cell a little bit. And if it's going to treat it in the opposite axis, you can overcorrect. Adjust the additional cylinder and topo ablation in the spherical correction. If you don't want to deal with the cylinder, just change the whole thing into spherical and treat that. And my suggestion is do the refraction yourself.
Thank you, Dr. Goyal. Can you stop sharing your screen if you're done?
Yeah, thank you. I would do
Uh,
that. Thank you.
Thank you, Dr. Goyal, for splitting the understanding of topo-guided regularization along with refractive correction in your own logical way. But it could be approached even more simplistically than that too. Um, just a question, I'll start with Dr. Titiyal. Uh, what would you do, doctor, if you have your uh, uh, topo axis and manifest axis are not aligned? Would you still do a contour treatment or would you do a wavefront guided treatment? Dr. Titya is not there.
Or is not there.
Dr. Namrata?
Yeah, I think Chitra, if they are not aligned with each other, then I think I would go in for a wavefront guided and not go in for a topo guided treatment.
What we have understood, Namrata, I'm sure you would agree with me, is that if the topo axis and the manifest axis mostly would align in a normal cornea, but if they're not aligned, maybe we would recheck the refraction, we would ensure that the topographic maps are ideally taken. But what we've understood is that if we use a manifest refraction and do a contour treatment, it works well in these one-off situations, and it has been consistently all right. So anybody else, Dr. Ritin, would you have anything to comment on that?
So, ma'am, the point of my presentation exactly is that
Yeah.
Alcon in 2016, when they got FDA approval for their contour treatment, they were working very hard in ensuring that the manifest axis is coming very close to the measured topographic axis. Now, my point is that when the manifest axis is very close to the topographic axis, these are normal corneas that don't have irregularity. So we're taking a regular cornea and trying to make it more regular. The point of a regularization treatment is going to be more important when they actually don't match. So my whole idea of telling you this, that let's convert it into a sphere, because these are normal corneas, the total magnitude of the spherical change that we'll be making is very small. Treat your go ahead with your refractive treatment as per your subjective refraction. Whatever topo regularization you're doing, just convert it into a sphere. This principle we were following for contact lens prescription 40 years ago, when we didn't have toric contact lenses. That's the time when we were talking about first order aberration and second order aberration cylinder, which we didn't have. Now we're talking about third and fourth order aberrations. It's not going to make a big difference. If we just convert that minute part into a sphere, I think we'll have good results, and that's my idea.
And what I also understand, I might conclude this, but if anybody in the expert audience would want to add, they are welcome.
Can I say something?
Who's that?
Kumar?
Yes, Kumar.
So I understood whatever you said in your presentation, that you converted to the spherical component. The difference was 0.18. Question here is very simple. You are saying that each one showed a board that next day I'm 6/5. If you are treated 5 and not the 0.18, he would still not be 6/6?
He is 6/6.
He will be 6/6.
He will be.
So
I'm not denying that.
what is the clinical significance of this 0.18 which you want to market, is my question. How much is clinically significant to the quality of vision to the patient? So do you have any studies on that? Because 0.18, according to me, is very difficult to measure clinically, and the patient will not be able to appreciate the value of vision that he or she is getting.
There is one argument for what you're saying too, but incidentally, all these patients have consistently done well. So whether I break it up into piecemeal the way Dr. Ritin did, but definitely one important message for the audience is
the irregular cornea, Chitra, I completely agree. There is no dispute. I am talking of every normal cornea to do this and to have a clinical significance where the patient appreciates. Then you should have a study where one eye you do that, other eye you do not do contura, and then see the difference in quality of vision.
Yes, there have been studies which have come forward. I'm not able to name them at this point of time, which have said it is favorable. It is not mind-blowing. Maybe one important thing we should take from this is that to an extent all of these products are then an oversell is being done. But if there is a very significant higher order aberration, if you see lot of coma and trefoil which does not correlate with your subjective refraction, those are cases where you should not do a contour treatment. We need not be as strict as the FDA trial by only comparing it with extremely normal eyes. But if there is a difference in the manifest refraction and the topo axis, you could still go ahead with the manifest refraction axis and do a great job of contour in these cases, is how I have understood, and I'm sure many of us would agree. I think Dr. Shreyas has not joined in.
Yeah, no, I would just like to comment on this. Am I audible?
Yes.
Very nice presentation, Ritin, and I think I agree with your conclusions in the sense that basically what we are doing today, we went through all these recommendations of Alcon, then tried 4 cities, etc. What we simply do is to get the manifest refraction, get the topologizer values as far as the higher order aberrations are concerned, combine these two together and go ahead and treat these eyes. And we find that the results are quite consistent. It is not just in our own experience. There's been a very large study conducted in Germany, a retrospective analysis, multicentric analysis, where more than 30,000 eyes were analyzed. Where they found was even when there was a very large difference between the topographic axis and the manifest axis, if they took the manifest axis, just combined it simply with the higher order aberrations and treated, these patients did quite well. As regards to Kumar's specific query about whether these 18 microns is going to make a difference, is here we are not talking about correcting refractive error, but we are talking about correcting higher order aberrations in a so-called normal cornea. So the very fact, by definition, the normal cornea is not expected to have too much of coma or trefoil. Yes. We are just trying to address those small aberrations and give a value addition to the patient beyond doing a wavefront optimized treatment. So basically a contour treatment is nothing else but a wavefront optimized with a topoguided ablation put together. The wavefront optimized is essentially given by the amount of refractive error that's corrected, and the topoguided ablation takes care of the small amount of aberration that's there on a so-called normal cornea, and this additively translates into a not only correction of the refractive error, but also a better quality of vision.
Yes. Thank
Dr.
you.
Chitra, can I, Dr. Chitra, one second?
Yes, Gaurav. Yes, Gaurav.
Okay, yeah. So I think Ritin explained very nicely what we typically were doing with Alcon contour treatments for the last 5 years with C4, C12 compensation for the refractive result, which was being induced by the, topography guided part of it, and which 4CDs does beautifully on its own, and you don't have to waste time on doing all that.
Yes, all this.
4CDs does it for you very nicely, and we use that. So we must do that compensation. Sometimes it will be significant and sometimes not.
I don't think for a C4, C12 compensation necessary for a normal cornea, Gaurav, I mean, I would absolutely agree with you if you are doing it for a topoguided ablation for an abnormal irregular cornea. But
most often, sir, in a normal cornea, the compensation will not be required much. I mean, you just need to look at those, and if it's a normal cornea, you probably won't need to do it anyway. But 4CDs beautifully does it for you, and you don't have to waste time, and put your mind to it. It works really well.
No, Dr. Ritin just made it a more joyous learning for us. That's all. Thanks, Dr.
I was just trying to explain how 4CDs calculates what it does.
Yes.
Absolutely, very nicely.
And just one small point to answer Dr. Gaurav, to answer Dr. Kumar, Doctor. Sir, I am not saying that this is the best treatment in the world. A lot of our patients without contour vision have excellent 6665 vision. I am just saying that this is the technology. This is how the technology has gotten better. LASIK was excellent 20 years ago. We don't have much scope of improvement, but this is definitely a step in the right direction, is what I believe, in my opinion.
Yes. Thank you, Dr. Ritin. We stay on with us. We shall now go on.